Good morning, y'all. Happy Thursday. I'd like to acknowledge my state of emotions most of the time. They're assumed to be great and wonderful because I get to hang out with you all, but I'm a little wobbly this morning because I was hit in a very vulnerable spot, which is my beloved compilation of schemas in Evernote, which failed me this morning. And I learned that I might have to do all those sketches all over again because Evernote made a major software update. So I'm in crisis mode emotionally, but there's nothing better to soothe that and to transition from the internal chaos of the privilege that I have in life is to worry about about things like that. Um, to transition to the space with y'all, but if you notice it, putting it out there beforehand. So welcome to another VMR. We're very, very happy to do version number 1 bajillion. This time I'm accompanied in the lukewarm seat by none other than Dr. Jas Bajwa. And as I prepare for these sessions, I of course try to like reflect a little bit on the journey of the person I get to do this with. This Thursday is meant to be a day where we get to really celebrate a colleague and a team member. And I was just remembering, Jas, you remember the first time we met, like virtually met? Over a clinical unknown. Yeah? Remember those days?
Yeah, it was a PowerPoint presentation and it had like all the personal details of you and Reza.
Yeah. Reza and I showed up, and Jazz's had hosted us at his former institution as a resident. And he was just like telling stories after stories about me and Reza as if he had listened to every single RLR episode forwards and backwards 3 times over. It was so endearing. Um, but the truth is, what's happened in the last 2.5 to 3 years is the exact opposite, where we've gotten the privilege of getting to know Jazz more and more and more, and have a bunch of stories, some of which we probably should never share out loud about him. And so I was just reflecting on that evolution of how well he knew Reza and I, and now how well we've gotten to know him. And I think that the beauty of that evolution and that exchange has been to see how much he's impacted the space. He's become a leader in VMR. He's synonymous with this word, and I think he still has a little bit of imposter syndrome. I don't think he believes that these words are still true, but I think that's really one of the most beautiful qualities of Jazz is the sheer humility that he carries himself. And of course, there's a price to pay for that when you're a touch too humble sometimes, which I will poke him as an accusation I level his way. But I'm very, very excited to discuss with him. But before I hand him the mic, try to keep it as quiet as humanly possible. I want to give a big shout out to the people who are making this happen today. First is Gerardo, who's scribing. Gerardo, do you want to say a quick hello?
Yes, hello everyone. Good morning. I'm Gerardo Luna. I'm a med student from Peru. I'm very excited to be here. Yeah.
Amazing. We're very, very lucky to have you be such a big part of VMR this week, Gerardo. I hear your voice frequently, and I'm thrilled. Equally thrilled is to see Moon, who has also been a pivotal aspect of VMR this week. I'll hand the mic to you to say hello, Moon.
Yes, it's really good to see you guys. I'm doing the teaching point, and it's a happy Lunar New Year. So I wish
Happy
the best
Lunar New
for
Year.
everybody.
Thank you so much. Happy new Lunar Year to everybody who's celebrating. I'd love to hand the mic to Jazz to say hello, and then we get to do the final honor of introducing our case presenter. Jazz.
Hey Robbie and hey everyone. Honestly, like Robbie always finds a way to make me blush, so that was too kind, and I can't thank you enough for how much the CP Solvers has transformed how I approach patient care since I was late intern year and when I was first exposed to this. So I'm honestly very grateful to be part of this family, and like being one of the leaders here is like even more just special. But that's all I'll say for now. I'm excited to learn from Pranay. I know he's on vacation while presenting this case, so we'll give it off to Pranay to introduce himself.
Hi, good morning, good afternoon, good evening, everyone. I'm Pranay. I am a first year intern medicine resident in New Jersey, and I'm very excited to be here presenting my second case this week.
Oh, Pranay, it's been a treat. I actually did the mental exercise of trying to remember when you first presented your case a long, long, long time ago. And so it's really cool to see your journey now and you're a full-fledged resident. How has the year been so far?
Yeah, it's been a little bit busy, but I'm really enjoying it.
Just a little bit, huh? It's very, very busy. I'm curious, how is the IMG dimension of the experience been compared to what you expected it to be?
So for me, New Jersey is kind of like a familiar place.
Yeah.
I have some cousins here, and overall, it was really amazing experience. Like knowing U.S. healthcare system and having this very supportive and careful colleagues, faculty. So it was amazing.
Amazing. Wonderful. I'm so happy to hear that. I hope we get to see you more and more often as hopefully the classical experience of residency is one in which your schedule lightens up over time and we get to enjoy the learning that you bring our way. And I say that because for those of you who didn't get to hear Pranay's case on Tuesday, you have to listen to it. So if you're tuning in and listening to this on YouTube, stop this. And we'll go back and listen to Tuesday first to give you a hint of what might be coming your way. It was a mind-boggling case that really tried to answer what is causing bowel wall edema and ascites in this patient, and the answer will have your jaw on the floor. So now that I've picked mine up from your from reflecting on your case, Pranay, I'd love to hand you the mic, and Gerardo, maybe you can share the screen and we can rock and roll.
So for first aliquot, we have a 60-year-old female presenting with progressive weakness of lower limb for past 4 months and shortness of breath for past 4 days.
You know, Jess, one of the best things about co-facilitating these is I sit here and I try to guide the conversation and do nothing else. And I'm really curious to tap into something that I don't think we get to tap into very much, which is reflexes. Because I think oftentimes we like dissect these things, but I'm really curious. This is such an unusual combination of things. I'm really curious what reflex thoughts are coming to your mind that help connect them.
Yeah, I think the acute onset and the progressive weakness, my system one thinking will automatically think of Guillain-Barré. I think that's the first thing that would come to now is this progressing to a diaphragmatic weakness.
Nice.
But to be honest with you, that's where I would pause myself and I actually would think back to something that you've taught us, Rabih, and that is when there's a 2-foot distance between the two organ systems, are they truly unrelated, or are they connected? But I think in this space, like I feel like those are two very alarming symptoms in a short period of time. And I would say right now, I would try to really see if there is something I can connect the dots in between. And what I would try to think to myself is there some type of neuromuscular junction or a upper motor neural lesion type of process that can connect the two? But that's what I'm initially thinking of to answer your original question about what reflex thoughts comes to mind.
Oh, I love that. I thank you so much for outlining that. And I'm curious now, like now that you get to slow down, how are you dissecting this? Take it further.
Yeah, so I really want to know, like, the progressive weakness. Is it proximal? Is it distal? Is it both? Did it really start from like the distal extremities and is it moving upwards? Or is it more just proximal? And is it really true weakness or is it asthenia? I think sometimes that is, patients come in and say they feel weak, but then when you get further history in the exam, they have good strength. It's just they feel the overall sensation of weakness. And if that's the case, then I would say asthenia has a much larger differential diagnosis than a true proximal or distal weakness. And then in terms of the shortness of breath, same thing. Like, is this subjective shortness of breath or is it objective, meaning like they have chest X-ray findings or they have hypoxemia, or are they just feeling the perception of shortness of breath? And is this patient really anemic? That can tie in the two together.
Yeah, absolutely. I think that essentially you're painting a very, very wide picture of what each could represent and trying to unify them together. And I'm right there with you. I think my mind is jumping to the overlap simply because of the probability of these two conditions being related based on the fact that they're both pretty unusual things to be happening simultaneously. And so I'm asking myself, like, what's my overlap of neuro and respiratory? And you can see already that I'm making the assumption that the lungs are the cause of the shortness of breath because neuro and anemia are rare, but certainly well described in nutritional deficiencies as an example. And even rarer are neuro and cardiac. You'd have to dig deep into inflammatory myositis and myocarditis, and that's pretty far down. So I think the leap in our conversation, the sort of metacognition, is how much more likely we are to find a lung issue in a patient who has neurologic disease open to a blood issue and definitely open to a cardiac issue, but way further down and way more esoteric. And then I think within the lung issue, you're absolutely right. Diaphragmatic disease is the most morbid association and the most elegant. I think an inelegant hypothesis is upper respiratory dysfunction and aspiration, which I think in most comers in most people with neurological issue and shortness of breath, it's probably that. But their neurological issue tends to be supratentorial, i.e., Alzheimer's, Parkinson's, so on and so forth. I think a couple of really morbid hypotheses to keep in your back pocket, only because of how morbid they are, not how likely they are, is obstruction. And so how can neurological conditions result in obstruction? I think the most intuitive might be immobility and obstruction of the pulmonary artery, venous thromboembolic disease. So if she hasn't been moving her legs for a long time, unfortunately, a clot can move and obstruct the lungs. And then most morbid of all and most esoteric is an entity called laryngospasm. So laryngospasm, I think we commonly know it as a drug-induced process, say in inhaled anesthetics, that causes the vocal cords to spasm. But let's remember that neurological disease doesn't just cause weakness, it causes incoordination. And there's a variety of neurological conditions that can cause spontaneous laryngospasm, including amyotrophic lateral sclerosis. And so some patients can die of sudden respiratory failure as a result of that. So I think the leap of faith that we can make, Jas, is really to anchor ourselves in what you said. We have to understand each individual element better to figure out how they overlay. But I think if you force them to be together as an artificial exercise, you end up prioritizing lungs over blood over heart. And then within lungs, you prioritize aspiration and diaphragmatic dysfunction, but are open to laryngospasm and venous thromboembolic disease. All these hypotheses are probably not something you would be doing right then and there, because as you said, a quick glance at the patient and 2 or 3 exam maneuvers can help you make progress on where this problem really is. And I'm excited for Pranay to shed light on that.
Amazing discussion. So for Aliquot 2, we have a 60-year-old female presenting with progressive asymmetrical weakness, acute onset shortness of breath, and chest pressure that's been ongoing for 3 to 4 days. So talking about her presentation, 4 months prior to presentation, she had progressive left leg weakness with sensory loss and 1 episode of urinary incontinence. At that time, MRI was done. MRI spine was done at outside hospital, and she was found to have severe degenerative disc disease with large paracentral disc herniation, for which an emergent discectomy was performed, and she reported symptom improvement for about 4 weeks after the surgery. 2 months prior to presentation, she had progressive left lower extremity more than left upper extremity weakness. Repeat MRI was performed, which did not show any spinal cord compression, no change, and limited EMG of left lower extremity was done, which was reportedly normal. 1 month prior to presentation, she was again admitted to outside hospital with again progressive weakness with distal more than proximal pattern. There was no sensory loss at that time. Cranial nerve examination was intact. A bunch of tests were done in outside hospital, and CSF studies were done, which was suggestive of lymphocytosis, mild lymphocytosis. Brain MRI was normal. Muscle biopsy was within normal limit. Myasthenia gravis panel was sent, which was normal. And at that time, after doing couple of other tests, presumptive diagnosis of AIDP was made, and she was treated with IVIG, intravenous immunoglobulin, and she reported subjective improvement in weakness, and then she was discharged. And currently, she presented to the ED with increasing shortness of breath and chest pressure for past 3 or 4 days. And the weakness is ongoing for last 3 to 4 months, and now it is progressive. She also reports gait instability. And additionally, she reports passing out whenever transferred from bed to the wheelchair. And that's the end of Aliquot number.
Oh, wow, Jas, what is your mind doing? I'm really intrigued.
Trying to capture all of that in real time is what I was trying to do. Pranay, that was a lot of great information. I think I just want to clarify something. Did you say that where did it go? I just want to make sure I read it correctly. I don't think the whiteboard is up there yet, but I was just wanted to clarify something that I heard. But in the meantime, I would say that the first thing that comes to mind here is she had this diagnosis of AIDP and then started feeling better. But oh yes, this is what did you say distal extremity more than proximal? Is that what you said? And it
Yes.
wasn't ascending, correct?
No, it was not easy.
Okay. So it could still be AIDP. I wonder about that, but I don't want to say out like diagnosis is too early, but I feel like when I see a distal weakness more than proximal weakness, I want to ask the patient, was there any also like back involvement, or like the back muscles and other distal extremities? Because I do think of inclusion body myositis that could also be, especially if this patient has been losing weight for quite some time and there's like a failure to thrive picture. She is in the right age range for that group, but again, not to anchor, especially because of like I have the differential for proximal muscle weakness is quite large, but for distal, it's not as common. So I do wonder about that. But that's the first thing that caught my eye in that large aliquot, Rabih. But I wanted to hear what you thought. Like, what stood out to you from that?
Yeah. I want to make note of the fact that you're being so brief here, in stark contrast to your initial response. And I think there's actually value for all our listeners to what just happened. Because actually, you know what I did? I ignored all this information. And because you know why? Because this happens to me in real life all the time. I'm sitting there, I'm meeting somebody new, and they have a very complicated story. And so the question before us for all of us is, how do you go about dissecting it? And what you can do is two things. You can listen intently to try to put clues that happened in the distant past, where you weren't there, where you don't have the data at hand, where the patient's memory is imperfect. Or you can first look and study what is happening before you, generate hypotheses, and then, with a much wiser, informed gaze, look back at this information. So here's what I do. I say, noted, thank you. Let me figure out what the foreground is. So I go back and analyze the background. And so for me, if we find normal reflexes, a little bit of muscle atrophy with predominantly flexor, lower extremity weakness in the flexor pattern in the legs, with extensor weakness in the arms, that is inclusion body myositis. If we find prominent atrophy, hyporeflexia, that's a nerve issue. So for me, I'm really, really curious to understand first what is happening in front of my eyes right now. And then I'll go back and analyze all this data. So when the patient comes in with a packet this big, I say, thank you. I'm not going to look at it right now. Although sometimes I will say though, you have to recognize that the patient is carrying that burden and might lose trust in you if you completely dismiss the value of that. So you have to be careful in articulating to the patient that it's really hard to digest all this information without first doing a thorough assessment of what's happening now. And so I think we have to study. You're staring at the text right now very closely, Jas. I'm going to be doing that too. But I'm not going to do that right now. I'm going to wait to see what the exam looks like, and then I'll go back and stare at it very, very closely. So, Pranay, why don't you give us the next aliquot? We'll see what we can make of this information in retrospect, as Jas was inclined to do.
Amazing discussions. So for aliquot 3, talking about past medical history, she has history of hypertension, dyslipidemia, anxiety, and a long medical history of chronic back pain, secondary to major motor vehicle accident decades ago. For social history, she does not smoke, she does not drink alcohol, no history of illicit drug use. Family history was negative as well, and she does not have any allergies. She's taking statin, rosuvastatin to be specific, hydrochlorothiazide, losartan, and bisoprolol for her medical condition. So for physical examination, on arrival to the ED, her vitals were temperature was normal at 98.5 degree Fahrenheit. Heart rate was 86, blood pressure 130/85, saturation of 96% on room air, and respiratory rate of 22. Uh, Talking about physical examination in general, she was looking distressed, but skin examination was normal. Hint examination, cardiopulmonary examination was within normal limit, normal S1, S2, bilateral air entry, normal breath sounds, and abdominal examination was normal as well. For her musculoskeletal exam, there was no joint tenderness, deformity. There was no edema that was appreciated in the extremities as well. And coming to neuro examination, for motor examination, left upper extremity strength was around 4 out of 5, right upper extremity strength 4 out of 5, left lower extremity strength 1 to 2 out of 5, right lower extremity 2 out of 5 in the proximal, 4 out of 2 out of 5 in the distal, and 4 out of 5 in the proximal. There was no fasciculation, DTR, deep tendon reflex 2 plus on bilateral upper extremity, 1 to 2 on both of the knees, left ankle 2 and right ankle 0. Talking about sensory examination, slight decrease to pinpoint in both back of the calves and normal pin and vibratory sensations. Otherwise, there was no cranial nerve deficit, and diplopia, double vision was also noted. That was improving little bit with time. So this is end of aliquot 3. I wanted to ask you what other labs or imaging you'd like to order.
Oh, so many, Pranay, so many of them. What an incredible output. So, Jats, you know what? I'll just share that I think we're gonna dive deep into neuro. So we do our listeners justice. I'm curious what you're making of the fact that this person reported shortness of breath, and what we found on that element, and then we can like spend some time on the neuro. So, what did your mind do with the dyspnea?
Yeah, I think that was actually one of the things I was thinking of, and I was looking at very carefully at the lung exam. Vitals are stable, not hypoxemic, not tachypneic, and it doesn't seem like anything on exam like crackles, wheezes, or decreased breath sound. So that makes me to what we originally were saying, that was this the perception of shortness of breath. So I would love to see if there's any ongoing anemia going on, or especially with the history we have so far with this being a predominantly neural involvement. I would be worried about diaphragmatic weakness, and even though the vitals are normal, I would be keeping a close eye on this patient to see if she can protect her own airway, especially if there is diaphragm involvement. And going back to earlier, we were initially the reflex that was AIDP, but timeline doesn't really fit. So I'll pause there. But like I was just saying that I'm not really worried that there's something structurally going on with the lungs. I think this might be either the perception because she's getting so weak, or there's the involvement of the diaphragm.
I completely agree with you. I think the vast majority of patients with shortness of breath, you're able to pick up a prominent clue on exam, be it volume overload, COPD, pneumonia, pneumothorax. So you ask yourself, like, if I don't pick anything up on exam, what does that mean? And I think it may mean that the problem is microscopic, i.e. in the blood, which you'll never be able to pick up on exam of the lungs. You may pick up on the exam of the conjunctiva, for example. Or the problem is macroscopic, but very, very deep, not reachable by your eyes or hands. And I think the two main deep problems are pulmonary embolism and diaphragmatic dysfunction. Those are the things that really evade almost everybody unless there are extra cardiac clues like tachycardia, EKG clues, weakness elsewhere. And so I think for me, as this very simple analysis of an underwhelming respiratory exam in somebody who's short of breath, is it actually a microscopic issue that you cannot see and you need the lab to diagnose? Or is the issue really, really deep in the diaphragm or pulmonary embolism? And so I'm right there with you. In the context of this case, it's hard not to worry about diaphragmatic dysfunction. And a really powerful tool that you can use at the bedside is two things. The first is to lie the patient flat. The diaphragm really does not like it when the stomach is in the way when you're flat. And so if there's prominent orthopnea in this patient, I think that would really make you worry. And then, of course, you can do a mean inspiratory force or pressure. which is a tool that I encourage you all to YouTube and look up. It's a very, very powerful tool. And both of those things are at the bedside. In the next 2 minutes, you can reinforce Jas's hypothesis of diaphragmatic dysfunction, and it is very, very crucial to do so. You don't want to miss that. So yeah, Jess, I'm right there with you on the respiratory element. I'm curious what you did with the neurological element. Where did your mind go?
Yeah, I'm sure Elena is having a ball right now because before we started VMR, she was hoping that this was going to be a neuro case. I think she's been sipping too much haterade from Deborah. So
Did you just say haterade?
Haterade is sponsored. It's an official drink sponsored by Deborah.
At her running club.
Yeah, and a running club. Yeah. So okay, I neuro is like by far my kryptonite. So I'm gonna try to break this down as much as I can. So based off the good thing I saw that the reflexes were normal. Oh, actually, no, sorry. Reflexes were normal in the knees, 1 to 2, but then the lower, like the ankles, were completely absent. And then that tells me that this, is involving like a peripheral process. And basically the upper extremities are pretty much spared. And then the distals are the ones that are basically that are being affected. And initially, I was thinking to myself, could this be when we first got the first article, could this be AIDP because they respond to IVIG and stuff like that? But the timeline doesn't really completely fit. It seems like it has a progressive course, maybe even a relapsing course over months, and it does have motor and sensory involvement. So I'm wondering, is it more like now in a CIDP picture? But I'm still worried about other things, like, for example, ALS, especially with the lower motor neuron signs. But the thing is, though, we didn't see any fasciculations. The EMG did not pick up on any other, concerns for like ALS. And then the other thing I was thinking about is maybe multifocal motor neuropathy, but again, does not completely fit. So I'll be honest with you, I'm a little perplexed. I still think this is more CIDP, but the other thing is because Pranay asked us what other labs are imaging. I would want to get pan imaging on this lady to see if there's some type of malignancy that we're not seeing, and could this be now a paraneoplastic causing infiltrative neuropathy, whether it's from a lymphoma, lung cancer, and the lung cancer may potentially tie in the shortness of breath, but it could be other malignancy in the abdomen too that may potentially explain a perineoplastic process. But other than that, I don't know what to take of this information. I would love to hear from you, Rabih.
Yeah, no, I think that it's funny. I don't know why I say yeah, no. Just thinking about that. Yes, yes. This is tricky, and I think your analysis is spot on. And most of us approach these things in different ways. And for me, when I hear that somebody's weak, I just lay out the neuromuscular axis from the get-go. And I think you can start at the top by eliminating the cortex here because the patient's thinking is so clear. She's able to tell you this history. So you're really now in the brainstem and below, and you have to think about the brainstem because the patient is having double vision. But if you truly have a problem in the brainstem, you would expect the reflexes to be elevated. And I think that the fact that they're not elevated makes a central cause, brainstem all the way down to the conus medullaris a little bit less likely. Of course, you can have normal reflexes in the context of a CNS process if it's acute, in the form of spinal shock, or if it's actually a CNS plus PNS. So B12 deficiency is a great example of how you can have a dual localization and the reflexes can be mixed. But I think the fact that the reflexes are not elevated pushes you to be outside of the spinal cord itself. And I think that is further reinforced by the fact that the majority of diplopia is really peripheral in nature. There are, of course, instances where it might be in the brainstem. And the majority of diaphragmatic dysfunction is also peripheral in nature. So not only do you have the base rate of diplopia and diaphragmatic weakness, presumed diaphragmatic weakness, but you also have the reflexes. And so the fact that this patient has distal predominant weakness is an argument against muscle disease, is a soft argument against neuromuscular junction disease, and it's pretty compelling for the nerves. And so for me, what is the likely localization here? I think the unlikely localization is muscle disease. The fact that this patient has hyporeflexia in some aspects and has sensory changes is a pretty decently strong argument against myasthenia gravis, which is a pure motor disease. Nothing else should be going on in a patient with myasthenia except motor issues. They should be, reflexes are preserved. And so I'll try this a different way. Nerves, muscles, and neuromuscular junction. I think it's probably helpful to break the neuromuscular junction down into two aspects: the presynaptic neuromuscular junction and the postsynaptic neuromuscular junction. And the presynaptic is where the nerve meets the synapse, and the postsynaptic is where the muscle meets the synapse. And postsynaptic NMJ disease looks just like muscle disease. Very, very similar, no, pure motor disease. Presynaptic neuromuscular junction disease looks exactly like nerve disease. The reflexes are down, there are sensory symptoms, and there are motor symptoms, and Lambert-Eaton does that. So I think for me, the localization here is nerve or presynaptic neuromuscular junction. And nerves are so much more common than presynaptic neuromuscular junction, but the only reason I'm entertaining a presynaptic neuromuscular junction disease is the presence of diplopia, a very characteristic NMJ disease, and also the hint of urinary symptoms in the past. So she did have urinary incontinence, but that was when she had a compressive issue on her cord. And so dysautonomia is a prominent feature of presynaptic neuromuscular junction diseases. She doesn't have any other forms of dysautonomia that I can see right now, but that's another thing to track. So if we just summarize this exam, Jess, I think that the fact that the reflexes are not elevated is a clue that this is a neuromuscular junction, or muscle disease. And the distal predominance, along with the hyporeflexia, argues against muscle and its NMJ cousin, postsynaptic NMJ disease. So I think the question is this a nerve issue or is this an NMJ issue? And I think that's when we might go back to the history and see, like, okay, if we're going to make that leap, how can we use the history in the past to help inform us? So I'm curious what you're making of now, looking back at all that paperwork, and how does that guide you or help you?
Yeah, I actually wanted to see what your thoughts are. I just want to make sure I read this correctly. So Pranay, it seems like there's asymmetric involvement of the areflexia, right? The right ankle was 0, whereas the left ankle was 2.
Yes.
Okay. So that makes me feel less likely for this to be CIDP. Because I would feel like it would be more symmetric. I guess it's possible, but it would go lower on the list. And then from what you said, I agree. I wanted to ask you, Rabih, in this case, when you see diplopia improves with time, I feel what I would really want to do is either ask this patient or take this patient for a walk and see if her weakness gets better with continued movement, or if it gets worse. I think that would really help. But taking into context of everything that has happened, I guess before I wanted to ask you, because a thought came into my mind, if this was more asymmetric, I would love to know why or why not would you think that mononeuritis multiplex be less likely, or would it be even worthwhile to have on the differential? I don't know the answer to that. I just wanted to ask you.
Yeah, I think that if you really have all the progress you can make is nerve or neuromuscular junction, and leaving it at that for now, you can break down nerve into the classic nerve predominant diseases that we see, which is this is not. So classic predominant, typically presenting axonal polyneuropathy would be sensory predominant, which this is not, would be slowly progressive, which this is not, would be symmetric, which this is not. So the 3 rules, slow, sensory, and symmetric, are broken here. So that pushes you to entertain the unusual forms of peripheral neuropathy, if this is in fact a peripheral neuropathy, which is either an aggressive axonal disease like heavy metal toxicity, which you are a champion of, or demyelinating disease, of which you've mentioned some examples already, or mononeuritis multiplex. So I haven't opened that box yet, because I think that is a sub box under the nerve localization. And the only thing that you can say is, if in fact this is a nerve localization, then it's definitely not a typical axonal neuropathy from alcohol or obesity or diabetes. It is one of those 3: atypical axonal, think heavy metal as an example; demyelinating, think CIDP or POEMS; or mononeuritis multiplex, or mononeuropathy multiplex, we should say. But I think the fact that you emphasize the diplopia, and that if there's dynamic changes with use, that suggests a presynaptic neuromuscular junction disease is why my mind is still in the higher category of trying to localize first before opening up the subnerve bucket. And so what I was going to do next was to see, okay, now that I'm thinking nerve and NMJ, or I should say more clearly, atypical nerve versus presynaptic NMJ, let me look back at this history with you to see if we have any guidance upon which way we should lean. So curious what, and as you said, we should go back and see and do the diplopia and see if it gets better with time. So looking back, what's your gut instinct on where this lesion might be?
I would say that looking back at the history, I would think this would be less likely to be, I think, a neuromuscular junction. Only feel like only because I feel like the EMG would have shown something. So I think this might be more of a peripheral nerve process, but I honestly will be honest, I'm not sure.
Yeah, I think you picked up on the key variable, to be honest with you, which is EMG, right? Like what is the value here of the EMG? And I think that the value of the EMG is through the roof when you're dealing with a peripheral nervous system issue. It's less valuable when you're dealing with CNS disease. And you're asking a key question: how can I use the fact that the EMG was negative to help me sway my possibility? And quite simply, your EMG can be falsely negative because the disease, it's too soon, done very early on. Or you have multifocal disease. You have disease in two compartments, as we learned last Friday from Hugh's case. Or you have an episodic neurological disease. And I think that's the challenge of doing an EMG in the context of neuromuscular junction disease, is the prominence of the need for repetitive stimulation to really bring it out. That I've seen that aspect be missed or overlooked several instances in the past. So would I be more surprised if the EMG was more subtle for an NMJ issue or a nerve issue? And based on no data, but just consuming cases, I think that EMG negativity has me leaning more towards the subtleties of discovering a neuromuscular junction disease, because I'd be so surprised if a horrific axonal neuropathy, demyelinating neuropathy slipped by an EMG. I don't know that for sure, but that's what makes me lean away. What further reinforces an NMJ hypothesis is that most cases of Lambert-Eaton begin in the legs and climb up to the body all the way to the eyes, the exact opposite of myasthenia gravis. But the counter arguments are that the patient shouldn't have a lymphocytic pleocytosis from Lambert-Eaton alone. So for me, I think what the history does, quite honestly, is it doesn't slam dunk. Just like you said, I'm coming to the same conclusion that you are, just with a lot more rambling, that the medical history, the look in the past, doesn't clinch it for me. So what would I do? I think you have to start from scratch and say, okay, what labs do we need to get? The first set of labs we need to get is to get a signature if there's any extra neurological elements. So if we see that the patient has low voltages on their EKG, that'll help us. If we see that this patient has a large lung mass, that'll help us. So I think in these cases, it can be very easy to fixate on the neurological dimensions, but studying any extra neural clues will be my first step. And then, gosh, repeating that EMG, because there's no way this process right now should evade an EMG. No way. So I think I would be doing those two things. Any holes in that next step phase that you want to plug, Jas?
No, that was beautiful. I agree. I was actually going to say, like, not all tests are perfect, and if the EMG was done a little bit early on, or if it's a multifocal process, I agree. I would really want a repeat EMG to see if we pick up something that was missed last time.
The only thing that's perfect is the perfect electrolyte balance in Haterade, Deborah's favorite drink. Highly encourage you all to consume it. Renee, what do you got next?
Yeah, so amazing discussion. We had all of these thoughts in our mind as well at the like what's going on actually. So for aliquot, for labs, basic labs, CBC, white blood cell counts of 10.2 with normal differential. Her hemoglobin was 10 with MCV of 90. The hemoglobin was kind of baseline for her, and platelet count of 400,000. Her serum chemistries were within normal limit. All electrolyte, sodium, potassium, chlorine, bicarb, BUN, creatinine, magnesium, everything was within normal limit. We did a CTHS because her presentation of shortness of breath was very acute, and it showed that she had right lower lung segmental pulmonary embolism. And echo was also performed at that time, and it showed that ejection fraction is normal with no RV strain. Talking about other labs, immunological workup, ANA, RF, C3, C4, C4 were within normal limit. ESR, CRP were within normal limit. HIV was negative, and neuromuscular junction panel, myasthenia gravis panel, everything was sent, which was also negative. Mayo Clinic motor panel was sent, which was negative for any significant antibody. And CT, pan scan, chest, abdomen, and pelvis was also performed for cancer screening, which was also negative. So this is the aliquot before the last aliquot, and the last aliquot will reveal the diagnosis.
Oh, wow. So, Pranay, just for clarification, that you'll reveal the diagnosis in the next aliquot, or is there one
Yes.
more?
Next aliquot.
Wow. Oh, Jas, we're up for a challenge. Next aliquot. All right, what you got?
Oh man. So I think the main takeaway I have from this this fourth aliquot was this is non-inflammatory. I'm like no significant leukocytosis. There's normal CRP, ESR. All rheumatology labs are basically normal too that were tested. HIV was a great thought, and that was normal. And then the CT, the pan CT scans did not show any nidus of inflammation or malignancy. So, and then even the repeat myasthenia gravis labs and the Mayo Clinic. Pranay, the Mayo Clinic, was it the paraneoplastic panel, or was that the Mayo Clinic?
No. So basically, it covers all the antibodies against GAD65. So I would say autoimmune plus other conditions. Yeah.
Gotcha. Okay, perfect. So, Rabih, what I'm thinking of this information right now, I'll be honest, like this is just an approach I have, like a schema I have for it, but I'm not experienced enough to say why one would be more or less likely, and I'll defer that to you. But I still feel like I think vasculitic and infiltrative neuropathy would still be possible if this is like amyloidosis, because I have seen cases of amyloidosis with no real inflammation. So that would still be on the differential part. Vasculitic, I seems like is now very less likely, especially with a normal ESR and well, more like CRP. But I would still say I would have CIDP on the list. I've heard of multifocal motor neuropathy, but I don't know too much about it to know if I think it's going to be a possibility here. I don't think ALS really fits, just based off the information that we've received in the neural workup. I will share a teaching point because I feel like I haven't shared many, but there's one teaching point that I've learned that most paraneoplastic syndrome, I wouldn't say most, a good chunk of paraneoplastic syndromes actually present before there's CT evidence of a mass. So I don't think it fits in this case, but just because there was negative imaging studies does not always rule out a paraneoplastic syndrome. But I think if I had to like summarize this data, this is a non-inflammatory progressive neuropathy with reduced tendon reflexes in an asymmetrical pattern. So I would be worried more about CIDP, but some type of infiltrative myelopathy or neuropathy could also be possible. But I would defer to you to see what you think.
Yeah, Jas, I think if I were taking care of this patient, I would think my distance to a diagnosis right now is still pretty high. And I think the reason I feel that and I see you articulating that is I think it just goes to show you that the EMG here, the missing element, in my opinion, would take me really, really far because it would have the ability to tell me, hey, is this a neuromuscular junction issue? Is this a demyelinating issue? Is this an axonal disease? Is this mononeuropathy multiplex? And so I think that that's the difficulty that I'm having. And just for one element of clarification, Pranay, so when you say the NMJ panel, does that also include the calcium channel antibodies for Lambert-Eaton as well?
Yes, it does.
Wonderful.
And I was going to mention this in the next aliquot, but brain MRI and spine MRI were repeated, which were also within normal.
Wonderful. Wonderful. Yeah, so I think that, we weren't investing in those two tests very much. So I appreciate Pranay laying them out clearly that they're not negative. And so, yeah, I think that if you ask yourself, what is the value of so we go back to our original localization, nerve and neuromuscular junction. I think that serological workup for neuromuscular disease is pretty darn good, but it's not perfect. But I think if you're not 100% convinced about an NMJ disease, I think those are pretty good tests to move you away from it, unless your pretest probability is very, very high. And maybe one other question. So, Pranay, is the CPK also negative? Presumably, at this point, you have that test.
Yes.
Yeah. So I think everything is pointing to a nerve issue, and the question is, what progress can you make by the relatively silent, cryptic nature of this? And I think you'll find that when you take care of these patients, or you listen to Aaron and others, there's two end diagnoses here that cannot be proven definitively, and that is amyotrophic lateral sclerosis and CIDP. And CIDP is a grab bag diagnosis essentially for a chronic progressive polyradiculopathy, but has many, many mimics along the way. And so I think what I would be doing is asking myself, are there any clues that are there any features that suggest those two diagnoses from the get-go? And I think one counter argument against ALS is the presence of diplopia. One of the most beautiful things about ALS is just how devastating it is in some aspects and how preserving it is. So you should have no sensory involvement in ALS, and we have sensory involvement here. You have no diplopia in ALS, and you have diplopia here. And so I think I'm moving away. I'm moving away from ALS. I see that I was just going to mention another hypothesis, but I see that Pranay, the paraprotein analysis was also negative. Is that right?
Yes.
Wonderful. We'll get to that in a sec. And so I think then you're on this journey of saying, okay, if it's unlikely to be ALS, is it CIDP? And I think that the challenge with CIDP is, if you find nothing else, you're probably labeled this as CIDP. And so the question is, what do you have to do before you label something as CIDP? And I think Pranay has done a lot of them. You got to rule out two key things, which is a paraprotein-related disease. Amyloidosis is a great example of that. You have to rule out antibody-mediated disease. And a recent entity called the paranodal antibodies are a notorious mimicker for CIDP. So I think assessing those things. But the final question is, do you have to ultimately get a nerve biopsy to rule out infiltration from non-AL amyloid, like transthyretin amyloid, which a family history here would be very helpful, to assess for vasculitis, or to assess for infiltrative cancers like neurolymphomatosis. So for me, my distance to an answer is very, very high. I think what would help me a lot is an EMG, and that would take me very, very far. And what would I be wanting? I would want to make sure that we do a heavy metal screen. I would want to make sure that we consider a nerve biopsy, but I think both of those things would be based on EMG. So I'm very far away from a final diagnosis because I'm so dependent on that entity. So I'm really curious to see how Pranay made progress in this case and learn from it.
Great discussion. So again, we were thinking along the same lines, and as I mentioned that we repeated MRI of the brain, MRI of the spine. So there was no new spinal cord compression. There was severe degenerative disease that was present on prior MRI as well. NCS was done, which showed normal sensory nerve response, and EMG was performed this time on all four extremities, and it showed that abundant fibrillation potentials and positive sharp waves, as well as frequent fasciculation, which was suggestive of motor neuron disease. So final diagnosis of ALS was made. And talking about diplopia, it was very subjective, as you were saying that why would there be diplopia, but according to her, it was very subjective. And then we went back to some of the history point that she mentioned, that when she was lying down, especially, she had some shortness of breath. A few months ago, she had problem with grief and everything. So retrospectively, it all made sense.
Wow, Pranay, that's a really, really interesting twist. Jas, what do you think?
It's just crazy. And it is because like EMGs are typically like pretty good. And like it was probably just too early into the disease onset for it to pick up that. I think, just shows you the power of repeating tests. Especially when like this entire time, I felt completely lost. But even you, Robbie, even you said that it was difficult to completely put a strong hold on what this might be, which I think whenever we feel like that, repeating testing is the take home point in this case. And it is an excellent case, Pranay. Thank you for bringing it.
Yeah, I know. I think there's so many different sneaky versions of ALS described. I would say the characteristic features that you can analyze on retrospect is the asymmetric involvement for sure. I think that's a powerful feature. I think the things that you have to ignore in this case to come to a diagnosis of ALS are the diplopia, which Brittany taught us to ignore, and then the episode of urinary incontinence, which probably was due to the disc extrusion. You also probably have to ignore a little bit the lymphocytic pleocytosis and ignore the previously normal EMG in the context of the limitations of that EMG, and that was done on just one extremity. And I think it just goes to show you that, that the most powerful thing to do in a complex situation like this is to meet the patient where they're at now and repeat all the testing where they're at now. And I think if you just look at the exam and you see a 60-year-old woman with asymmetric whole of all four limb weakness, without an inflammatory signature, I think you really start to wonder and suspect that diagnosis. And it also just goes to show you the power of the EMG, in my opinion, because the EMG could have showed anything here. I think it could have showed evidence of mononeuropathy multiplex. Could have showed evidence of demyelinating disease. And so I think that it's just so hard to make that diagnosis without the EMG, in my opinion. And so I think the fact that that test took us so far is, I think, a powerful learning point for everybody to show you just how important that test is in peripheral nervous system disease. So very, very humbling and educational case. I'm curious, Pranay, what did you learn from this journey? What were your takeaways?
Same as you were mentioning, Dr. Ravi, that sometimes we anchor to particular diagnosis, but in this case, a lot of atypical things were present, like sensory involvement, but it was because of the degenerative disc disease and the previous EMG, which was normal, but it was very limited EMG of left lower extremity. So in retrospect, all of these things, and then we again took some of the history, and in retrospect, all of this were very, very much, logical.
Wonderful. Clearly you're learning a lot in residency, and I know it's just a little bit busy, but all that time of yours invested is taking you far. And thank you so much for lighting up our week this week with such incredible educational cases. I hope everybody listening is inspired to do the same and to come share your wonderful learning with everybody here. So thank you so much, Pranay.
Yep.
Alrighty, the mic is yours. Take it away.
Yes, thank you so much for great discussion and case. It was very wonderful. Okay, so for a 60-year-old patient with progressive lower extremity weakness and shortness of breath, consider tempo acute and just mentioned about GBS. Also consider about neuromuscular junction environment and respiratory muscle. Look for ascending weakness and ask for whether it is true weakness or not, and true shortness of breath. Differential includes diaphragmatic weakness, venous thromboembolism, and laryngeal spasm, and also consider neuro and cardio environment. Focusing on the current clinical finding is more important than focusing on the past medical history. For patient with a distal weakness greater than proximal weakness and normal reflex, we consider about muscle atrophy and myositis and hyperreflexia. We should consider neuropathy. And for the patient with shortness breath, patient was having vital sign was normal, no crackle, so consider anemia or pulmonary embolism, and diaphragm weakness. And Robbie mentioned about putting the patient bedside flat caused orthopnea, suggesting diaphragmic weakness. And then we talk about a lot of differential diagnosis for the peripheral CIDP for demyelinating and axonal heavy metal and motor neuropathy multiplex. And ALS, even the patient had a diplopia and no fasciculation and EMG of no abnormality. We also consider about ALS and neoplastic neuropathy with a lung cancer as a potential cause, and also spinal cord or conus medullary pathology, but it was less likely with hyporeflexia. And we also consider neuromuscular junction disorder with the diplopia, presynaptic lumbar return syndrome, dysautonomia, or postsynaptic NG, similar to motor and muscle disease. And Jess mentioned that we should do some repetition to clarify this, and EMG repetition is necessary, and also to look for lung mass. Non-inflammatory progressive neuropathy with a reduced reflex, really pointing to CIDP, and infiltrative neuropathy like amyloidosis and vasculitis, even though normal CRP-ASR and less. Yeah. And yeah, so it's so we did a even the patient has neuromuscular junction channel was normal, CT brain and spine MRI is normal, no mass, ruling out neuromuscular junction disorder, pointing to the neuropathy. And we are thinking about CIDP and heavy metal screening and consider nerve biopsy for further evaluation. But repetition of EMG showed a fasciculation pointing to ALS, and diplopia can be subjective, so the final diagnosis was ALS. Thank you so much for a wonderful case.
Thank you so much for a great recap of a very, very tricky journey. I really, really appreciate it. Pranay, I'm curious if you wouldn't mind shedding light on one aspect of this, which is how you communicated this diagnosis to the patient. I imagine that must have been very, very difficult.
It was, and the thing with this ALS, generally natural history of ALS is kind of 6 months to 1 year, but for this case, it was very rapidly progressive. So that was also one of the other issues in this case for diagnosis. But she kept to have this continuous weakness. Then she also had weakness with her diaphragm, and it was a very, very bad trajectory, I would say.
Fortunate diagnosis for sure, and one that also is, there are many morbid conditions in medicine, but some of them also have a social element to them given how widely known they are. So ALS in the United States has a lot of social connotations, and I think a lot of disproportionate social fear, not because of how deadly it is, but disproportionate compared to other conditions with equal mortality. And so it's a very, very tricky news to share with the patient. Jas, final word to you, my friend. What do you want to tell people before you go?
That neurology is truly complex, and I appreciate all future neurologists out there, just because I could never be a neurologist. It's too complex, and it just. But this was a great case, and like I definitely have a lot to read on, ALS itself, but even CIDP, and see how it can be better for next time. But this was great. Thanks again for the co-discussion, Rabih.
Well, pleasure is mine, my friend. I think the goal is to have enlightened conversation with neurologists and be able to learn from them, not take their job. I'm right there with you. Bye, y'all.